us during our presentation. It's fairly informal. Right, so we'll start with the introduction for breast anatomy. So it's a modified apocrine gland that produces milk. It's not your simple sweat gland, so it's fairly complex. And it's superficial, consists of glandular and supporting fibrous tissue and embedded in a fatty matrix, okay, together with your blood vessel, lymphatics, and also nerves. So it's an accessory reproductive gland in female, rudimentary in males. It doesn't do anything there in males. And the shape is hemispherical and pendulous as well. Embryology, it begins to develop as early as the 4th week in utero. And you could see the mammary ridge, which extends from the axilla to the inguinal region. So it will actually, so the nipple will actually develop along these lines. So if you were to have supernumerary nipples, which some people do, it will actually form along these lines, and about 90% form in the thoracic region, and then 5% of people will actually have it in the axilla, 5% in the abdomen. In the female breast, the lobule formation will occur, and it occurs after puberty. And each lactiferous duct is connected to a tree-like system of ducts and lobules, and enclosed by connective tissue to form a lobe of the gland. So that forms the parenchyma of the breast. So the location when you go into surgery, initially you would actually mark where you would do your incision and plan your surgery. And usually I would see, especially would kind of mark the second and the 6th rib. So that's going to be the superior and the inferior margin of your breast tissue. The medial edge is your sternum. The lateral edge is your mid-axillary line. 2/3 of the floor is actually the bed of your breast is covered by your pectoral fascia here, and 1/3 of the fascia is covering your serratus anterior muscle here. And at the superolateral corner, you've got the axillary tail spans. So that's your surface anatomy and also the location of your breast tissue. So structure, skin, you've got nipple and the areola. The parenchyma is the functional part of your breast tissue. So that's basically your mammary gland, produces milk, and so that's the parenchyma. And it also consists of stroma tissue, which is the supporting tissue around your breast. So you've got your Cooper's suspensory ligaments, which is also called the Cooper's ligaments, and also your fatty tissue. Moving on to the nipple areolar complex. So it's covered by thick skin with corrugations, and you've got about 15 to 20 lactiferous ducts passing through. So nipple and areola actually contain smooth involuntary muscle arranged in concentric and longitudinal form. So it actually can erect, and the nervous system is neurofemoral. So at the dermal papilla at the tip of the nipple, it has numerous sensory nerve endings and mesenous corpuscles as well. Okay, your areola here is pigmented. As I said before, there's involuntary muscles there arranged in concentric and radial. And then the epithelium of the areola will contains sebaceous glands, and during pregnancy, this will enlarge and lubricate the nipple during lactation, and these are also called the tubercles of Montgomery. So parenchyma, this is the functional part of the breast tissue. So you'll start off at the ductule. These are the part of the breast tissue that produces milk, and then it will drain into the intralobular duct and then onto the extralobular duct. So this is called the terminal ductal lobular unit, so TDLU. And then these will actually drain into the interlobular duct and then go on to the main duct. So you can just translate it here actually. So, and each of these are these glands here, represents the glands there. So the stroma is divided into two. You've got the fibrous stroma and also the fatty stroma. So the fibrous stroma is the one in orange here. So it's suspensory ligaments of Cooper. So this attach the fascia of skin and pectoral muscle. So swelling and edema around these ligaments will actually cause the peau d'orange appearance when you have cancer. So in cancer as well, it causes fixity of gland and puckering of the skin if the cancer invades the fibrous stroma. So in fatty stroma, you've got the subcutaneous up at the front here, and then you also have the retromammary fat. So these actually provide the bulk of breast tissue. All right. So the arterial supply. So I find it useful to kind of start from medial and go to lateral. And there's four main blood supply to the breast. So the first one is your internal mammary artery, also known as the internal thoracic. So it's a part of subclavian artery. Which branch is it? Is it the first, second, third, or fourth? Internal thoracic. First is actually vertebral artery. So
second.
Second, yes. So this is the second branch of subclavian artery. So I would remember the subclavian artery branches as vitamin C and D. So V is your vertebral, and then I is your internal thoracic, or also called the internal mammary artery. So this will actually supply the middle part of your breast, and it sort of provides the vasculature for 60% of your breast tissue. The perforating branches pierce the first to fourth intercostal spaces and then traverse into the pectoralis major to reach the breast along its middle edge. Okay, the first and the second perforators up here are the largest out of these branches. So the medial internal mammary also is the main blood supply for your nipple areola complex. Okay, so if you want to do any nipple conserving surgery, you have to look after the arterial supply from these branches. Then you would move on to thoracoacromial artery. So this. Okay, sorry, technical issue. So then you would move on to the thoracoacromial artery, which is a branch of axillary artery. So this will supply the superior part of your breast. And then you have your lateral thoracic artery and its mammary branches supplying the superolateral part of your breast tissue, mostly lateral part of your breast tissue, and then you have the smaller ones here, which is the intercostal arteries, and you have your posterior intercostal arteries and the lateral mammary branches, supplying the lateral part of your breast tissue. So venous drainage, you've got the subareolar venous complex, and then it drains, it kind of follows the arterial as well. So it drains into the internal thoracic or internal mammary vein, and then drains into the subclavian, if I'm not mistaken. And then you have laterally, you have your lateral mammary and lateral thoracic draining the upper part. The posterior, it also drains to the posterior intercostal vein, and they actually communicate the internal vertebral venous plexus. So this is why cancers can metastasize to the vertebra. So lymphatics, you've got your subareolar plexus of lymphatics below the nipple, and it's also called the plexus of Sappi. So 75% of the 75% lymph will actually drain to the axillary lymph nodes. So your axillary lymph nodes groups, you've got your apical, lateral, central, anterior, and posterior, and 15% into the internal mammary. So this can actually go to the left, to the contralateral side. So upper part can go into the supraclavicular. So the lower two quadrants can actually go to the subdiaphragmatic abdominal nodes. So here they can actually metastasize to your liver, and then also possibility of metastasis to pelvic organ, and then give you Krukenberg syndrome, which is also metastasis of your ovary. So in terms of axillary dissection, so if you are clearing level 1 and level 2, your landmark is the pectoralis minor. So level 1 will be actually medial to your pectoralis minor, and then second will be underneath your pectoralis minor minor muscle. So you only clear level 1 and level 2 most just because there's no difference in morbidity if you clear all three. So innervation, the cutaneous innervation is actually from the anterior and lateral cutaneous branches of 4th to 6th intercostal nerves. It passes through the pectoral fascia to reach the subcutaneous tissue and skin. It conveys the sensory fiber from the skin and also sympathetic fibers to blood vessel and smooth muscle, the skin and the nipple as well. Right. So this is actually this question actually came up in Medex. I took it 2 years ago before I entered masters. So so it's a fairly common thing that they would expect you to know prior to entering masters. So thoracodorsal nerve, C6, C7, and C8. So it supplies the so these are the nerve injuries that you would sort of want to be careful about when you do axillary dissection. So the thoracodorsal nerve supplies the latissimus dorsi. How I remember it's dorsal here, dorsi here. So thoracodorsal supplies the latissimus dorsi, and it depresses the shoulder. So if you injure this during the operation, you will have a problem to actually raise, so AB abduction of the shoulder. So long thoracic nerve. So if it's C5, C6, C7, let's have a look. So this is a long thoracic nerve, and you've got your thoracodorsal nerve here. So long thoracic nerve, it causes it supplies the serratus anterior. So injury to this nerve will actually cause waned scapula. So axilla, so it's actually a truncated cone. So if you go back in your own time and kind of have a feel of the surface and have a feel of your axillary boundaries and contents, it's, like I said, it's a truncated cone. We'll start with the anterior wall. So anterior wall is actually the pectoralis major, pectoralis minor, and also the clavipectoral fascia. So the posterior wall is made up of subscapularis, teres major, and latissimus dorsi, and this is actually the floor of your axilla. So it's held by suspensory ligament, and like I said, it lies between the anterior and posterior axillary fold, deep fascia of the arm, and also your serratus anterior. The medial wall is your serratus anterior to fourth rib. The anterior wall is your, sorry, I've covered that. The lateral wall is the intertubercular groove and also your biceps tendon. the apex of your axilla is your clavicle, your scapula, and also outer first rib. So the contents, I think probably just have to remember that your long thoracic nerve is the most medial, and vein is more medial than the artery. So axillary vein is more medial than your axillary artery. So when you do an axillary dissection, you would encounter your thoracodorsal bundle here, and then your long thoracic nerve is actually a bit more deeper than your thoracodorsal nerve. So thoracodorsal nerve here along with the bundle, and then long thoracic nerve a bit more deeper. So just talking about axilla, so I'll just cover axillary artery and axillary vein before ending. So axillary artery, I think most of us know that it's divided into first, second, and third part, and it's divided by the pectoralis minor muscle. So it's easy. First part has one branch, second part has two branches, third part has three branches. So the first branch is superior thoracic. The second part is behind the pectoralis minor here. It divides into the thoracoacromial and also lateral thoracic. All right, and the third part, which is at the lateral edge of pectoralis minor from here until the lower border of teres major, and it's got three branches, which is subscapular, anterior and posterior circumflex humeral. Axillary vein, formed at the lower border of teres major muscle. So union of vena communicans of brachial artery, and then also the basilic vein. So and then it drains into the axillary. Those two drains into the axillary vein, and then runs upward on the medial side of the axillary artery, and ends at the lateral border of the first rib, and then becoming the subclavian vein. So this, I mean, in terms of operative significance, your subscapular vein, which is this one, quite multiple and lies in the posterior wall of the axilla, and usually they're encountered during the surgical clearance of axillary lymph nodes. Any questions before I pass on the presentation to Rema? Nope.
Okay. Shaza.
Yes,
Hello.
yes, yes.
Go back to the location of the breast.
Location of the breast.
Initial slide.
Me.
This one. What's so important of knowing this location of the breast?
So yeah, for mastectomy, so before you planning for prior to mastectomy, you need to mark all this, and you need to take, if you're planning for, you need to ensure that you get all the breast tissue in a mastectomy.
Yeah, so this is the the gross anatomy of the breast. So you need to know this in terms of mastectomy. Okay, simple mastectomy. Okay, so you must know the landmark from the second to sixth rib, or sixth rib you can another one that you can grossly expected is at the inframammary fold. Okay, at the inframammary fold. So that's another way to know lah. Okay, other than you kira the ribs also, one of them, and also the inframammary fold. So usually you can a bit extend lah from the sixth rib to lebih sikit. Sama juga from the second rib tak adalah ambil second lead betul-betul, but you have to like extend a bit because you takut you tertinggal a bit of the breast tissue, isn't it? So the landmark is the second to sixth and the lateral edge of the sternum. Okay, you can palpate from the outside kan, the sternum and the edge of the sternum, and then at the laterally at the mid axillary line, that one is a superficial anatomy. But when you do mastectomy, inside of the flap itself, your landmark is the latissimus dorsi. Okay, the lateral edge is at the latissimus dorsi. Okay, all right. Okay, go to the blood supply. Okay, blood supply. Okay, this blood supply, isn't it? Regarding the perforatus, okay, perforatus it comes from the area of the sternum. So in this perforatus, and usually the second, the largest, you have to be very careful because it is from deep inside the chest wall and it come up to supply the breast. So when you do mastectomy in that medial side of the area, you need to be careful of this perforatus because satu dia besar, okay, it can cause bleeding, and some more if it snap inside the chest wall, macam mana you nak cari, isn't it? So you have to be careful. So maksudnya usually you use diatomy, right, to cut everything, but in this area you have to be slowly dissect until you find this perforatus. Okay, find this perforatus. Okay, so untuk selamat, sometimes you dissect a bit away from the edge so that you jumpa and then you ligate and then you can, after you secure the perforatus, then you can senang hati sikit lah you nak dissect around these medial areas. Okay. And then blood supply of the nipple areola complex. Okay, so basically because some mass is at the retroareola. So macam mana ni you nak dissect lesion at the retroareola because you afraid of the nipple necrosis, isn't it? So your skin incision must be not more than half of the circumareola, must be no more than half. Okay, because you want to preserve the blood supply to the nipple areola complex. Okay. Okay, next apa lagi? Venous supply. Venous supply ni tak ada apa-apa lah. Okay, apart from the metastasis to the vertebrae. Okay, and then lymphatic drainage lah. Lymphatic drainage, this is quite a glamour soalan. Okay, lymphatic drainage of the breast. So you must know the axillary lymphatic channel is the main bulk, and then it can also goes to the abdomen. Okay, to the abdomen. Alright. Okay, that's all untuk breast lah.